Good morning, everybody. Just giving a couple of minutes there for people to join the session. You're very, very welcome to our webinar today, which is all about counting the cost of arthritis, a report on the financial and personal burden of living with arthritis. And we're delighted that you could join us here today. My name is Gráinne and I am Chief Executive here in Arthritis Ireland. Just to start off by just saying that we are actually recording today's webinar. So we will be posting it after this session as well. So if you're not able to stay on for the whole thing, or if you know of anybody else who might be interested, we'll be publicising the link to this webinar after we finish today. So just to go through a few slides before I hand over to our researchers. And that is just a little bit about Arthritis Ireland, and just to kind of alert you to the fact that you can find out everything you need to know about what we do in Arthritis Ireland by calling our helpline on 0818 252 846 or logging on to our website, arthritisIreland.ie. Many of you here today probably know a lot about what we do already, but Arthritis Ireland is here for everybody that is living with a diagnosis of arthritis, and for family members also. We run a range of support services, including educational courses, physical activity programs, and we also publish a range of information booklets, information videos. So there's a wealth of information and support available to you on your journey with arthritis. And the best point really is to maybe log on to our website, as I said, or indeed our helpline, and one of our volunteers will certainly support you and point you to where you can get the best support. So I'm just going to move on now to talking a bit about the purpose of our webinar here today. And today we are sharing the findings of a really important piece of research that has been something that Arthritis Ireland has wanted to do for a very long time. And we have finally brought this piece of research to fruition, and we're here to share those findings with you here today. So just to give you a little bit of background to this piece of research, in May 2024, we reached out to our community to ask them to respond to a detailed questionnaire that we had spent some time developing with researchers in the School of Population Health in RCSI. I'm delighted to report that over 1,600 people took the time to respond to that questionnaire, which was a very detailed questionnaire, and a huge thank you to everybody who completed that questionnaire. The data collected from the questionnaire, offers really valuable insights into the personal and financial burden that arthritis imposes on people and their families. And those findings were then analysed by the research team at RCSI School of Population Health. As I said, the research would not have been possible without the commitment of so many people who really took time to complete the questionnaire. And as I said, over 1,600 people did that. So the findings are really rich as a result of that. So today's agenda is, first of all, I'll be introducing you to Jan Sorensen and Gintare Valentelyte from the RCSI School of Population Health. And they're going to present the findings of the research to you. Then after that, we'll have a panel discussion with Jan and Gintare, and that we'll also be joined then by Peter Boyd, who lives with arthritis for over 10 years and is also working within Arthritis Ireland as well. And then there'll be time for any questions that you have, questions that have maybe come into your mind as you've listened to today's webinar. So please do use the Q&A function to pop in your questions during the webinar. A little bit of housekeeping just before we move forward. Everybody but the presenters and the speakers are on mute, and cameras are off, okay? As I said, please put your questions in the Q&A function in Zoom, and we'll hopefully, get to address as many questions as we can during the allotted time, and that allotted time is 15 minutes, okay? And we will do our best, as I said, to respond to as many questions as we can. And lastly, what I want to do is, first of all, again, to thank everybody who answered the survey, but also the research would not have been possible without the support of our sponsors of this study. And those sponsors are Novartis, UCB, Pfizer, and Celltrion Healthcare. So a huge thank you to those 4 sponsors who supported this research. And now we're going to move forward to the presentation of the findings. And just to give you a little bit of bio on our 2 presenters and then on our panelists later on in the session. So first of all, I'd like to introduce you to Jan Sorensen, who is a professor of health economics at the School of Population Health, RCSI, in the University of Medicine and Health Sciences. And then we have Gintare Valentelyte, who is a health economist and a postdoctoral researcher at the School of Population Health in RCSI. And lastly then, delighted to have Peter Boyd, who's our Services Support Officer here in Arthritis Ireland, who's also lived with arthritis for over 10 years and was a collaborator in the development of this, this research questionnaire. So delighted that all of those people could join us here today. And without further ado, I'm going to invite Gintare to actually begin with sharing the findings from the research. So you're very welcome, Gintare.
Thank you very much for the lovely introduction, Gráinne, and it is a great opportunity to present to you today. So I hope you can see my slides. And today I will be running through some of the initial phases that we were involved in while developing this survey. So first of all, the survey focused on capturing the personal costs related to arthritis. And what do we mean by personal costs? So these are any private payments that an individual has paid in the last 12 months towards their arthritis condition and managing their condition. And often these type of costs, personal costs to the individual, are not usually considered in many instances when we look at health economic evaluations or health technology assessments for new treatments and care provided in other countries, including Ireland. And some examples of such personal costs include healthcare provision, costs that an individual paid towards their medication, towards help in the home, or home adaptations, among many other types of costs. So moving forward to the methodology and what did we do while we developed the cost questionnaire. So we followed a co-design approach, which meant we involved quite a lot of people in developing the questionnaire. So at the development phase, we had people living with arthritis. We also had people with professional experience with arthritis. We had Arthritis Ireland, as well as economic researchers from RCSI, School of Population Health, who all came together as a group to discuss this questionnaire and why it was important. In terms of the design phase, we met multiple times and everybody discussed and we all agreed together what important costs and which most important costs and information should be included in the cost questionnaire. After we developed this initial questionnaire, we had a small group of people who tested the questionnaire and got back to us with any other additional feedback and any other revisions for some of the questions. And finally, once everybody was happy, we shared the questionnaire across the Arthritis Ireland network through emails and social media channels. And so the final questionnaire, if some of you were involved in providing us answers to the questionnaire, the final questionnaire included quite a lot of information and detail. So we had information. We asked about the respondents, about their age, their education, for example. There were questions about each person's disease and their arthritis conditions. We also wanted to understand about the general health status of individuals. We also wanted to understand more about the sleep quality and the impact of arthritis on that. We also included quite a few questions on mobility and assistance, on employment status, as well as additional questions that were specific to healthcare services and transport, as well as other services like medical expenses and medical products. We also included a few questions which were specific to additional financial support that individuals received for healthcare, for example, private health insurance or any other financial support that individuals received. So this was our cost questionnaire. I will now hand you over to Jan, who will go through some of the key findings of the report. Thank you.
Thank you very much, Gintare. So as Gráinne has already mentioned, we had responses from 1,612 individuals who provided answers to our online questionnaire. As Gintare has outlined, it was quite a complicated questionnaire. There was different sections, and within each section, there was a lot of detailed information. We had responses from, out of the 1,600 people, 85% of those respondents were females and 14% were males. The average age was 60 years of the respondents, and that there was a huge range in age. The youngest was 18 years old and the oldest was 92 years old, but the mean age was 60. We asked about how long time respondents has been living with arthritis. And again, there was a large variation. Some people had just been diagnosed with the disease. Other people have been living very long time with the disease. The average time that the respondents had been living with arthritis was 12 years. We asked quite a detailed question about the type of arthritis. And that was a complicated way of doing that because there can be many different combinations of arthritis and musculoskeletal diseases. 33% of the respondents indicated that they had rheumatoid arthritis. 30% indicated they had osteoarthritis, and 12% had PSA, psoriasis arthritis. 60% of the respondents indicated that they also had other health conditions. Hypertension was very predominant. Asthma, COPD, and lung diseases were another group, and mental health conditions were some of the high-frequently diseases. But there was a wide range of other diseases that people were living with on top of their arthritis. We asked about people's sort of social protection, and 33% indicated that they had a medical card. 23% indicated they had a GP card, and 73% indicated that they were part of a drug payment scheme. 70% of the respondents indicated that they had a private health insurance, and 46% indicated that they have a life insurance policy. So this is a description of the people who have been responding to this questionnaire. And that is important to sort of make when you interpret the results that I'm going to present to you now. So one of the sections we asked about was the current health status. And here we used a very common scale, the general health scale, that has 5 categories where people can identify what is their current health state. This general health scale is used in many different circumstances, conditions, and you might already know that from the census. Every census that has been administered for the whole population is using the general health questionnaire. And we use that in our survey, and 1,542 people responded on this part of the question. Now, this was quite a surprise for us, especially when we compare these responses to other data sources that we have. 20% of the 1,500 people who responded to this questionnaire indicated that they had poor health. And poor health is the worst health category that is available in this 5-category scale. 35% indicated that they had fair health. 32% indicated that they had good health. And 10% indicated they had very good health, and only 3% indicated to have excellent health. Now, we wanted to, as such, it's a bit difficult to make interpretation of that, except we can see that the health state of the respondent are relatively poor. But we have also access to data from the Healthy Ireland survey, and that's a national survey. And we use data from 2 waves in 21 and 23. And in that survey, 22,000 people had responded to the same question as people in the Arthritis Ireland survey. And you can see here a really stark difference between people in the general population represented by the Healthy Ireland survey and the respondents in the Arthritis Ireland survey. So in the Healthy Ireland survey, the representative sample there, only 1% indicated that they had poor health. 2% indicated they had fair health. And that is, you can see the severity of the health of this respondents here. 13% in the general population indicate that they have good health. 43 and 42% indicate that they have either very good or excellent health. So this information is really giving a very firm indication that the people who responded to the survey with arthritis, their health state is really much worse than people in the general population. We used another instrument for measuring the health-related quality of life, the EQ5D, and that's another generic health instrument. It's relatively simple. Instead of having just one question, there's 5 questions, and each question have 5 levels again. And here, 1,500 people responded to the EQ5D, and 70% indicated that they had problems with mobility. 97%, nearly everyone, indicated that they have problems with pain and discomfort. 80% indicated to have problems with usual activity. 65% indicated to have anxiety or depression. And 35% indicated that they had problems with self-care. Again, this is giving the firm indication that the respondents' health-related quality of life is really poor in comparison to good health or in comparison to the general population. Now, one of the advantages of this EQ5D is that there is an Irish algorithm, there's Irish data that enable us to take the data from the EQ5D and score on an index ranging from 0 to 1, where 1 indicates the perfect health and 0 indicates death. And if we apply that scoring algorithm to the data that we have, we get an average estimate for the 1,500 people on a score of 0.58. And we can compare that to the general population. General population using the same instrument, using the same scoring algorithm, would have a score that is over 0.9. So again, here we have a clear indication, and we have a numeric size of the poor health that the respondents in our survey had. So we could also try to analyze sort of subgroups of people, of the respondents, and see, could we find a pattern in the poor health status? And we could identify that male in general reported better health status than females. We had the expected age gradient, so people with higher age, they reported a poorer health status. We had length of education, patients with, or respondents with longer education reported better health status. And people with longer duration of arthritis reported poor health. And we could also see there was a strong correlation between the EQ5D and the general health questionnaire. So all these findings that we had on the quality of life is not really surprising, but it's confirming the expectations that we could have from the outset. And it just adds to the credibility of this data that we have analyzed here. It is behaving as we expect it to behave. We are getting the responses that we would expect. On top of that, we also have the numerical analysis that we have analyzed, so people can actually go in and see how much better are male and females in comparison to each other. So we also asked about the private cost related to rheumatoid and musculoskeletal diseases. And the result that we come up with here is that on an average person with arthritis over a 12-month period will have 3,538 euros as personal cost or cost out of their pocket. And we then can divide that into where does this cost arise from. Nearly half of the cost, nearly 2,000 euro, relate to purchase or user payment of healthcare services. Nearly 1,000 euro relate to medication and medical products. Nearly 500 euro relate to assistance that are required due to arthritis, and 100 euro relate to help at home. But the main finding here, 3,500 euro, is as the mean cost, the mean personal cost is the main finding. And you might ask, how did we come up with that number? And I'll explain that in a bit more detail. So we first asked about the use of different types of healthcare services. We had 28 different health services where we asked people to identify how many times during the last 12 months have they had visits, physical visits to each of these service providers. And you can see the numbers here, and you can see the different service providers. On average, a respondent had, or the average respondent had 27 visits to a healthcare provider during a 12-month period. That is quite a lot of contacts. We also ask respondents to say, how, out of these, or for these different services, these different visits and contacts, what were the user payment? How much did they pay for that service? And this is the second graph is showing the average cost for each of these services. And you can see there's a big variation in the cost that people have to pay for these services. So over a period of 12 months, the average person is paying nearly 2,000 euro for healthcare services as private cost, out-of-pocket payment. We could then analyze the variation in these average costs, and we identified that females pay a higher cost than males. Respondents with higher age paid a higher cost. People with longer education paid a higher cost. People who have had arthritis over a longer time paid a higher cost. And people who indicated on the general health questionnaire to be in poor health status paid a higher cost. All again, these findings here, the trends that I'm just reporting here, are no big surprise. And in a way, that's very nice because it confirms the quality of the data set. And we had expectation of all of these findings, but we now have actual numbers to say what is the impact of, what is the difference in cost for different groups of respondents. So we have added some new knowledge into the field. We also asked about people's other personal cost, and medical products was one of the bigger parts of where people have personal cost. That relates to prescription medicine, over-the-counter medication, and other types of medical products. Here we just asked people to indicate what was the 12-month cost that they had paid themselves. So these are the numbers, and the average respondent indicated that they paid nearly €1,000 for medical products. We also asked people how much they paid for mobility and assistant products and services, and the average amount was around €500. And you can see the distribution of private cost in this graph here. So that was a breakdown of the personal cost. But seeking healthcare is also requiring time to visit the healthcare provider and requiring time to transport. And in our questionnaire, we had quite a detailed section on people's time and transport needs. And we identified that the average respondent spent 52 hours. So that's the 27 contacts or visits to healthcare providers. They spent 52 hours in a 12-month period to get healthcare. And in addition to that, they use 54 hours to transport themselves to the healthcare providers. We could see that the time spent was proportional to the number of visits to healthcare providers. So people who have few visits also spend less time than people who have many visits, who spend more time on visiting and transporting them to the healthcare providers. We saw a very strong gradient in relation to the general health questionnaire. So people with poor health spend much more time on seeking healthcare and transporting them to healthcare. I mean, this again is not a big surprise, but we have now documented the numbers for different categories of respondents. We could also identify that people who are living in rural areas, they had higher transport time. Again, that's not a big surprise, but we have some numbers that can justify that sort of statements. Now, arthritis also have consequences for employment. And we asked, we had a section in the questionnaire on employment consequences. And in this analysis, we have identified the responses for people under the age of 65. So that is people who are in the age group where we expect them to be able to hold employment and be in the labor market. And that related to 632 people. 58% of the 600 people indicated that they were in active employment, and 63% of those 58 in active employment were working as full-time employee. A third or 37% indicated that they were working part-time. 60% of those who indicated that they were working part-time indicated that arthritis was a reason for their part-time employment status. So this is an indication that arthritis really have implications on people's employment and their ability to work, at least in many cases. Out of the 600 people under the age of 65, 31% indicated that they had retired. And that's probably also a high number, especially considering the retirement age is normally over 65 years old. We asked a question about whether people have, because of arthritis, whether they have experienced a loss in income. And 70% of the 600 people indicated that they had experienced a reduction in their income. And those who indicated how much indicated a mean loss in income of over 3,000 euro per year. So not even arthritis is these data here indicates that arthritis have great impact on people's ability to work, but also have impact on the income that people get from the work if they are in employment. Now, the questionnaire also included some free text comments. We asked people to provide additional comments about cost that they might have experienced that was not covered in the questionnaire, and they could provide additional comments. And we really have a rich set of respondents or comments on these two aspects. All the responses that we have received have been anonymized and are presented in an appendix of our technical report. It's really interesting reading and very thought-provoking reading to go through. In the Arthritis Ireland report, we have identified some of the statements, and you can read them when you browse through or read the report from there. I will sort of, I've just given a small taste of the results from this rich data source. We are planning to do further analysis. We have already done a bit more analysis in the technical report that you can download and read for yourself. But we want to use these data to analyze more aspects. For example, we want to assess what is the impact on health-related quality of life on arthritis, do a more thorough analysis of that. We also want to do further analysis on the cost implication of arthritis. We want to explore the variation in healthcare needs and personal cost. We want to test the sort of balance between public funding and private funding. And we want to explore the employment consequences in further details. I want to end this presentation by extending my thanks to all the people who have responded to the questionnaire. It took on average 20 minutes for each person to complete the questionnaire. Some people were faster, some people took even longer time. But that's a considerable amount of time to respond on one single questionnaire. It was quite complicated, so we really appreciate everyone who have taken the time and completed the questionnaire so carefully. We also want to thank Arthritis Ireland for their interest in personal cost and for helping organizing the outreach to the questionnaire to our network and helping us analyze and interpret the results. And finally, I want to thank our patient representatives for their support and help in doing this analysis, helping us to understand the wide cost implication of arthritis, helping us in designing and testing the questionnaire, and helping us to analyze and interpret the results. So thank you very much. I think that's it for me.
Thank you very much, Jan and Gintare. Thank you very much for sharing those findings. And just to remind people, like there's a lot more in the report. Obviously, we'd be here a very long time if we went through everything. So there's a lot more in the report. So really encouraging you to have a read through that after today's session. I also just wanted to name the three patient representatives who worked really closely on the development of this questionnaire. It was a lot of work, and I just want to name them. Peter Boyd, who you see here, who's one of our panelists today, Claire Knievy, who I know was on the webinar, and then Tim O'Sullivan as well. So just to really thank all of them, because really, really important that we got that involvement from the very start in scoping out the questionnaire. And I think the team in RCSI really, there was a real richness, wasn't there, to their involvement in every aspect of the design of this study. So thank you very much to them. So we're going to move to the panel discussion part. And before I do, just reminding people, if you have a question you'd like to pose to the panel, please do pop it into the Q&A box that you'll see on the ribbon there on Zoom. So pop your question in there. And my colleague Tara is monitoring the questions there. So if it's something that doesn't come up in the panel discussion, we'll hopefully have time for it before we wrap up the session, okay? So, right, so the panel discussion, Jan, the first question I'm going to put to yourself, that is this. Look, the report reveals an average cost of €3,538 per person with, higher expenses for those reporting poor health. What specific factors drive these, increased costs for people that have poorer health, and how do they impact the overall financial burden?
Yeah, that's a good question. Thank you. I mean, €3,500 per year is a lot of money, and that's an average number, and so it means that some people pay less and some people pay more. And if you see the distribution, there's people who pay considerably more than the 3,500. When we analyzed the data, we could see that there was a strong correlation to people's health state. And in a way, that's not a surprise. So people who have a poor health state or indicate that they are in a poor health state, they spend more money, they have a higher use of healthcare services. And because they have using health services more, they also have to pay more for that service. So it hangs together in that way. As the numbers indicated, nearly half of the person expenses were on user payment for healthcare services, and that could be GP services, it could be hospital services, but it could also be privately indicated physiotherapy and other services that were not prescribed by the public sector, but where people believed or thought that they would have benefit from providing or having additional services. And if it's not prescribed by the public sector, then people have to pay it themselves. So there's the number, the €2,000.
Or they can't access it. That's the other consideration. Sorry, they can't access it in the public system in a timely manner or at all. So therefore they pay privately.
Yes. Yeah, it's not prescribed. So it's not so they have to go out of the public system and get it themselves. And then they have to pay the full price often to get that service. So nearly three-quarters of those costs relate to healthcare. We have the €2,000 for healthcare services, and then there's an additional €1,000 that relates to the pharmaceutical or medication and other supplies. So that is a breakdown of these costs.
Okay, thank you, Jan. Gintare, the report indicates that 31% of respondents under 65 are retired or unable to work, and with 89% attributing this to their arthritis. Were you able to uncover like the primary factors contributing to such a high rate of early retirement or inability to work among this group? And have you any idea about what interventions could potentially help to reduce this impact?
Thank you very much, Gráinne. That's a really good question, and I think it's a really important one. And, as Jan indicated in the key findings, I believe, and we've seen in the report that, the reason so many people are saying that they're retired or cannot work is clearly related to their poor health status, as we have seen in the questionnaire, and which is an indication of the reason why people cannot work if they have poor health. And in addition as well, in some of the open comments, some individuals have also said and expressed to us that, employment and work is a very important part of individual self-identity, and it's part of their daily routine. And for some people, it was quite difficult to give up their work. So we saw, as Jan presented, a lot of these respondents had to opt out and work part-time. And, you know, another aspect is it really depends on the type of work that an individual is involved in, you know, whether it's an office desk-based job or whether it's an outdoor job. And, you know, so I do believe a combination of these factors can contribute to why we have seen so many respondents indicating that, you know, they had to retire. And moving on to your second part, you know, in terms of interventions and what could potentially help these individuals, I think the first and maybe the more obvious idea would be in terms of interventions for employers. So, you know, realistically, it would be down to the employers to create and provide work circumstances which will enable and encourage people with arthritis to stay in employment, you know, whether it's providing additional support in, for example, you know, encouraging people with arthritis to take more regular breaks or organizing shorter meetings, and many other, you know, accessibility, many other aspects that could be done. And in my opinion, the intervention would come down to the employers in order to, you know, have maybe less people having to opt out and retire from work. And, you know, in order for this to happen, this is where probably the government could step in and incentivize and possibly work with some employers and provide, you know, some, whether it's financial contributions or grants, and, you know, further enabling employers to keep people with arthritis in their workplace.
Okay, thanks, Gintare. One of the things then that we looked at in the report as well, and in the course of the research, you know, was in relation to kind of health status, and there was a number of questions around that, which was a really important part of this research as well. Peter, you know, 89% of respondents reported sleep problems, so, you know, very large percentage, and that was down to their condition. While almost 20% reported that arthritis severely impacted their sleep pattern. As someone who's lived with arthritis for over 10 years, can you tell us about the impact that sleep interruptions have on your day-to-day life?
Yeah, it's a massive impact. It's like arthritis in general impacts on every aspect of your life. But when it comes to sleep like there's a reason sleep deprivation is a form of torture. It's taken away from every aspect of your recovery. So your sleep is there to recover from the day before, to get you prepared for the next day. And if you're rolling over onto a shoulder or a hip or a knee, and that pain is causing you to wake up, then you're not going to be as recovered from the day before. You're not going to be as prepared for the day that's coming. So you're going to be in more pain, or you're going to be more stiff than you were. You're going to be less productive. You're going to have less motivation to be active and do your exercise, your activity that it is. You're going to have less ability to be motivated to get out and do things with your kids or your job or whatever it is, your hobbies. You're not going to have the extra energy to be able to do the cooking that we need to do, or the movement and the cleaning that we want to do for our head to make us feel better. So all of a sudden then you have more pain, you have more, your head is getting at you, you're giving out to yourself because you're not doing these things. You've ordered something from the takeaway or something easy into the oven from the freezer, so it's processed food. It's costed you more because that's more expense that you don't have with money. But then you're also then beating yourself up because you don't want to be doing these things, but you don't have the energy to do it. All of these things mean that you're not ready to have a good night's sleep again that night, and the cycle begins again. And so it's a whole vicious cycle of things that go on. And it's trying to break it at some point to find the place where, and it's hard to know whether it's the chicken and the egg, but all you know you have to do is break it somewhere. So if you can get that sleep sorted out, whether it is finding a way to make your joints more comfortable at going to bed by doing your stretching exercises, or by moving a little bit just before bed, or it's your sleep routine and your sleep hygiene just before you get into bed that makes sure that you get as long as sleep as possible. And then that makes you that you're more motivated and more ready for the next day that's coming. That's it. But it's a huge impact. Like I've been living it, as you say, for a long time, but I still get impacted. We have enough of it with our kids waking up in the middle of the night. We have enough of it when, you know, as we get older, waking up that we need to go to the toilet. There are enough interruptions in our normal sleep patterns that happen. We don't need the extra ones of a painful joint or anxious about our finances, anxious about everything else that's going on in our lives. These are extra ones brought on by our condition. So the more we can minimize them and then the impact that they have on our day-to-day life, that's where we're going to see improvements. And the more rested we are, the more capable we are, and the more able we are to carry on with the day-to-day life and the normal, quote unquote, life that we want to lead.
Well, thank you for that. And I'm sure lots of people listening will be able to relate to that fully. Jan, back to you. The report shows that respondents with poor health status spent an average of 156 hours on healthcare visits, you know, compared to just 60 hours with those that were deemed to be excellent health. You know, this significant time commitment, you know, raises concerns about how individuals manage their employment, their family life. Can you share your thoughts on the broader implications of this finding?
Yeah, I don't think the sort of finding is surprising. I mean, people who are in a poor health state will have more use of healthcare services, and therefore they have to spend more time on transporting and spending time on their healthcare provider. So I think that is quite well understood, and we have now documented that. I think one can speculate about the appropriateness of that, and that really relate back to the organization of their healthcare, because we want to have services that are close to where people are living. On the other hand, we also want to have, if we have a serious disease, we also want to have specialists who can provide specialist care. So I think in one of the analyses that we are going to look at in more detail is what is it that is driving this transport time and the time? Is it GP services? Is it physiotherapy services? You can argue that that should be close to where people are living, and therefore it's high volume that is being used, and therefore it should be close to where people are living. That might be efficient. But if it's a specialized, going to rheumatologist or hospital services, I think many people prefer to go and spend a bit of time getting to the specialist who can really understand the disease and provide the appropriate treatment. And that requires sort of that people are moving into the specialist centers. So there are sort of trade-offs, and that is a broad conversation about how is the health service organized in Ireland. How do we separate between the frequently less specialized services and centralizing the very specialized services into fewer centers. As an economist, I understand quite well that when you specialize services, you also reduce the cost of that. So it might be quite expensive to spread the specialized competences out in a big area, and it's much more efficient to have it centralized. Also, it relates to how can you recruit the specialist, because I don't think specialists can thrive in an area where there's not a lot of colleagues. They sort of they want to be in groups where they can share their experiences and develop their competences, develop the care for patients, and that can only happen in the specialized services. So it's this sort of centralizing, decentralizing health services is really complicated. And it's, in the end, it's a political sort of assessment, what is the most appropriate thing. But I think for the patient who have to get the care, that is a challenge. And we have to do, the health service has to do what they can to provide transport services that are cheap and easy, perhaps, for people who have high use.
Yeah. Another question for you, Gintare, you know, in relation to poor health status again, you know, so we talked about, you know, 55% of respondents indicated poor health status, compared to just 2.5% in the Healthy Ireland studies, which I think is like a stark contrast. What do you think are the factors or conditions that might explain this stark difference in health status between, you know, people with arthritis and other musculoskeletal diseases and people in the, if you like, in the regular, the population as a whole?
Yeah, that's a really good question. And I think 55%, the fact that more than half of the respondents to the cost questionnaire have indicated poor health, you know, that's quite a substantial result in itself. And, you know, if we're to kind of dig a bit into why that might be, I think the obvious answer here is, you know, arthritis is having a severe impact on people's general health, which is why so many people have responded and indicated poor health status. I suppose in terms of factors that contribute to this, you know, it clearly relates to the type of arthritis, disease and condition, and as well as other additional conditions that an individual has, which clearly would contribute and have, as we know from the responses, have contributed to this poor health status. Other factors like how long an individual has been living with arthritis, their age, their level of education, you know, their employment status, all of these factors, among many other, you know, the obvious one, the financial burden on a day-to-day basis for an individual, these all can, you know, collectively contribute to this 55% finding that we have in terms of poor health. And I suppose, you know, one kind of side comment or side note is, you know, when looking at this result, it's really important to note that in many instances and by human nature that, you know, there could potentially be some element of reporting bias, you know, if we're asked as individuals to respond to certain questions about something that's maybe a little more negative. Some people may be more inclined to, you know, kind of overestimate or over-report some findings. So I'm not saying that was the case in the survey, but we do need to be quite cautious that, you know, some people who did report poor health status may not always be living with poor health. You know, could have just been in that the day they filled the questionnaire or they completed the questionnaire, on that particular day, they were feeling poorly, you know. And I suppose when comparing the 55% to just 2.5% of the general Irish population, you know, who are saying they've poor health, I mean, it's quite a stark difference. And, you know, Ireland is one of the few countries in Europe who is known for, you know, the general population rating their health quite high. You know, as Jan showed us the comparison in the key findings, that over 90% of people rate to have pretty good health in Ireland. So, you know, it's great that we can compare our questionnaire responses to our population level responses. And again, it is, you know, we have to kind of take some of these results with caution in a way, because it's quite a crude measure. And, you know, there are other and possibly better ways of capturing general health of people. So just being mindful of that. But having said that, you know, there are many factors, as I described, and, you know, a lot of other factors that we didn't get an opportunity to analyze just yet in detail, and which we hope to look at in, you know, subsequent publications and research.
Okay. Thanks for that. Peter, the report highlights that 97% of respondents experience pain and discomfort, which in turn, you know, significantly affects their quality of life. Given this common and challenging issue, how have you personally managed pain and discomfort since your diagnosis? And, you know, what strategies or treatment have been most effective for you?
There's a few things to unpick there, because I would certainly agree that 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 amount of people are talking about pain and discomfort, and I think that leads into their reporting of their health condition as well, because I think that's what people are thinking and what they're feeling. So I wasn't surprised that the number was that high, reporting a poor health, because it impacts on so many aspects of your life that you just feel so overwhelmed by it. I think that's true. And with managing our helpline and seeing the things that people are talking about, every single call that we get is mentions pain and stiffness and discomfort. So again, I'm not surprised that 97% of the respondents mentioned pain, because that's a common thing for us to discuss and to do. But there are so many different things that can be done. Medications are obviously there. They're one aspect of it, but they're very much an aspect of it. As you can probably see, I have one thing there on my wrist for my thumb at the moment. It's just a support to try and do it. There's aids, there's different gadgets you can get for around the house that can help you to do all these things. But oftentimes these are additional costs that we have had to put out for and do on our own bat, and we'd have to see things that might help us around the house. And you know, it's important that we kind of are willing to take that chance that this will work, because, and if you can afford to take that chance, both mentally that might not work, but also the financial cost that you've spent some precious money on something that may not make a difference for you. And that's a very difficult thing to get your head around. But asking about what makes a difference for pain and discomfort, I think it comes down to your acceptance and your head at the end of it all. I had times at the very beginning where if I was in the same amount of pain 2 or 3 years after my initial diagnosis, but I didn't feel the pain, if that makes sense, as much as I did at the very beginning, because I understood what it was. I knew what it was. I had it diagnosed. I had a name put on it. I was on my treatments, and I could kind of get to terms of what was happening, that I wasn't making it any worse by what I was doing, my activity. And I could kind of understand by talking to other people who had arthritis, and I could kind of get a feeling for what I was going through. And I think that was more important, of accepting what was happening, rather than being so anxious and fearful about the truth. And I do feel that's an important aspect of it, that we talk about it and we don't shy away from it. There were other times where I said, you know, oh well, if I'm in pain in the future, you know, I just won't get down on the ground and play with my children, or I won't do things. I'll protect everything. But through experience, you learn that sometimes you just have to do these things and you have to get on with it, and you will be in pain, but it's knowing what you can get on with the next time, and what you can put up with. It's a cruel place to be, when you know that something you're doing is going to cause you pain, and you're going to be in pain the next day or something like that. But I think if you have in your head that this is an unpredictable condition and I might be in pain anyway, so if I can do something that I'm really enjoying and I get some value from, and that may give me more pain, as just as much as if I do nothing and I still might be in pain, well then hopefully the distraction and the good memory will be enough to get you through. But it's so difficult to come to terms with living in pain that's there the whole time, and it's trying to come to terms with that and manage it is a difficult thing. And I'm certainly not an expert in it 15, 16 years down the line, but it's day to day trying to manage it.
Thanks, Peter. Not easy. Yeah, no, thank you for outlining how you manage it and what you found effective. Jan, the overwhelming response to the questionnaire, along with detailed personal comments, look, it provided significant context to the findings. Is such a high level of engagement, typical for this type of research? And what does that reveal about the experiences of those living with arthritis?
Yes. I mean, we developed a complicated questionnaire. And it was difficult there was a lot of details of information that people probably didn't sort of have ready available. And the average respondent took 20 minutes. We can see that to respond to that. So they really have to commit to sort of provide the information. So I think there's other elements that it might be difficult to identify people who should respond or who are potential in the target group for this questionnaire. But also when they open up for the questionnaire, then it might be a bit overwhelming. But I think I've been close to the responses, and I have been impressed by the accuracy and the detail that people have been adding into the questionnaire, and the accuracy that people have provided on the answers. So I think we are quite proud of the data, and we are very satisfied for that data to be able to provide some valuable information about the cost of arthritis. Having said that, although we have worked quite closely with our PPI representatives and Claire and Tim and Peter and yourself in identifying what are the main costs, we had a much longer list of cost items that we ideally wanted to have included in here, but we excluded because we needed to condense the questionnaire, and we needed to have the questionnaire sort of reasonable and couldn't have all the details. And we can see on the text responses that we have been missing cost items that people have had. So it means that our cost estimates is probably an underestimation of the real cost, especially if you're not having included all the costs that are relevant here. So that, on the other hand, this is the first time, I think, in Ireland where people have been offered an opportunity to report their person cost and out-of-pocket payment. So we have to sort of learn, and I think we will probably in the second, if you're doing a new round of questionnaires, there might be tweaks in the questionnaire that we might do. Some of the cost items we might take out because we can see that very few people are using them, then that's not necessary to have. And there might be other items that we need to include because we can see from the free text that is an important and omitted cost items that we should have included. Mm. So, yeah, I think that's my thoughts. Thank you.
Peter, back to you. Look, the report shows that 116 respondents received an average of over 700 hours of unpaid help from informal caregivers. What does this reliance on, informal caregiving reveal about the supports needs of people with arthritis? And, how can we better support both those living with arthritis and their caregivers?
It tells us it's very common that people will do it in a heartbeat for their loved ones. We'll do what we can. I would imagine that a lot of those hours are also people living with arthritis themselves, doing it for their parents or their spouses or their partners or their friends who are living with arthritis as well, and they are prepared to do it because we care, and we know that it has to be done because we understand what somebody else is going through and living with that, and that's great. And like I read a comment this morning about somebody who had done a full-time job, basically 40 hours a week of driving somebody to appointments, and like that's such a huge commitment to do it. We need to use that now as a way of advocating for change and for getting more official recognition of this as a force support for carers, for people who are doing it, because it's such a huge amount of time and energy that's been put into it. It can go down as simple as whether it's having people on our forum, on our Facebook forum, talking to each other and giving support. That's one element of it, right the way up to driving to appointments, driving, doing the shopping for you. All these things that we sometimes take for granted. And even like it's including things with your partner, you know, cleaning the house for somebody because you take on the task because you can and somebody else can't. So it's very much an element of we do so much because we feel we just do it and we don't even question it, but we've got to take this figure and this amount of care that's being provided for people and really action it now, because you know it's over and above what should be required of people on an individual basis.
Okay, thank you, Peter. Just looking there. We thank you for that, and thank you to our panelists for this really great discussion on the findings, and really kind of adds that richness to the research. We're now going to move in the last few minutes of our webinar to Q&A, and there have been some questions coming in, and my colleague Tara has been monitoring those questions, and she is going to put some of those questions to the panel now.
Thank you, Gráinne. Hello, everyone. Gráinne, actually, one of the first questions that we have is for you. Actually, you might be able to answer this one. So we've had some comments here from people who really welcome the report, and they're wondering what the next steps are for Arthritis Ireland now going forward with the findings.
Yeah, of course, like really good question. So, I mean, our focus obviously for the past while has been on, you know, the development of the questionnaire, the implementation of the research, and now the publication of the findings. So, look, we're absolutely delighted that, I suppose, the findings back up what we would have thought, that obviously people with arthritis do have you know, a significant financial burden and a personal cost burden. So what we will be doing over the coming weeks and months is actually formulating a plan around that. I mean, obviously we're in a general election cycle at the moment, so we will be, you know, prioritizing the next actions that we need to take, and it will form part of our advocacy work. And part of that advocacy work will absolutely will be forging relationships with the new government. So obviously, with the election happening next week, the formation of a government, it will be in the new year before we actually action that. But it's important that we take the time now to look at the findings and to put together a strong plan around how we can affect change in this area.
Thank you, Gráinne. Peter, I have a question here that I think you probably should take, and it's from someone who's wondering where they can meet other Arthritis Ireland members or community to share. They feel like they're a broken record to colleagues, friends and family, and they're looking for support.
Yeah, 100%. So Gráinne gave the phone number of our helpline earlier, which is available. It's 0818-252-846, and you know, leave a message if you can't get through to us immediately. We'll get back to you and speak to you. But we also have our online forum. It's a Facebook forum there. It's Arthritis Ireland support group, and that's bringing together people with all sorts of different conditions. And arthritis, rheumatological conditions, related diseases. And you can share stories, you can talk to each other, ask questions, and it's a really good way of reducing that sense of kind of isolation, but it also gives you an opportunity to do just that, events and people who understand exactly what you're talking about. So that would be the two places to go to.
Thank you, Peter. There's one comment in here really, and it's just a follow up on Gintare's point about workplace and supporting people who are, you know, want to continue working or want to return to work following an arthritis diagnosis. And they mention a pilot project that has been ongoing in Trinity College in the occupational therapy department. I believe it's called WorkAble. So they just want to mention that as well, and that it would be fantastic if there was a national rollout for that programme, which I'm sure we would all agree would be welcome. We also have another question here for Jan. I can put this question to you here. And essentially that is, this person was wondering if there is more money spent by certain people depending on the condition that they have. So are there some conditions that, you know, impose more of a financial burden on people than others?
Yes, we have analyzed that in the report at some detail. So I would refer that person to go to the technical report. And there's some breakdown of different combination of arthritis and the average cost for that. But the point is, yes, there is some variation, but that variation has to be adjusted for age and sex and things. So it's a bit more complicated to come with a very clear answer on that. But there are certainly some indication in the technical report.
Thank you, Jan. Gintare, I might put this question to you. You mentioned that Ireland rates very highly in relation to our European counterparts in terms of, reporting good health. Are there any similar studies such as this that were carried out or have taken place in other European countries that we can compare with?
So at the top of my head, I did not actually come across a similar study for outside of Ireland. So I'm a bit afraid to say, in terms of how do we compare, or how do the results from this report compare to other EU countries. But I'm sure, if we dug a bit deeper in terms of what research has been done, I would suspect, from my own intuition, that we may not find so many more studies in other European countries who would have actually put so much time and effort and resources in rolling out and sharing a questionnaire like the one we have, presented on today. So, but we'll see, maybe the results from this report might encourage other countries to take a similar approach.
Great. Thank you very much, Gintare.
Tara, can I just
sure,
come in on that? Because I think Ireland is when you compare the health system in Europe, and I have the advantage that I've been 8 years in Ireland, so I have a good understanding of the Irish system, but I also have understanding of other systems. And what strikes me is the complexity of the Irish healthcare system. There is a private sector, there's a public sector, but a substantial private sector where people are either relying on private health insurance or private payment. And the system is geared towards that. And then on top of that, there is a substantial amount of user payment. Every time you go to the GP, there's a fee to be paid. Every time you go to the A&E department, there's a fee to be paid. And of course, there are some exemptions. But I think Ireland, the health system in Ireland is quite unique with this sort of financial structure. And I think when the question is, will there be other studies in Europe that has been looking at private expenditures or private costs, then the need for that sort of information is perhaps not as big as it is in Ireland, because there's so much reliant on user payment or out-of-pocket payment in the Irish system. And that's something probably that the system has developed over a long time, and it's sort of political. How have you organized the health service, and how is that going to be funded? But it's certainly a topic that is very potent to address now when there's an election, and whether some of those financial mechanisms for healthcare should be changed. Of course, it can't be changed overnight, but it's small, subtle changes that can happen. But the reason why I don't think there's, and I agree with Gintare, I don't think there's many similar studies in Europe, and I think the need for this type of analysis is not as big other places in Europe as it is in Ireland here.
Thank you very much. I think we're going to have to wrap it up there, as we're just about to hit 1:15. So I'm sorry if we didn't get to everybody's questions today. I'll hand it back over to Gráinne.
Okay. Well, just remains for me to thank you all for joining us this lunchtime. If you know of anybody who would like to hear about the report, we will be publishing the link to this webinar. We have recorded it, so we're hoping that many more people can hear the messages and the findings of this research. Thank you for joining us, and thank you very much to our panelists today for joining us as well. And particularly for the panel discussion. I think that just added a real richness to the findings and the research that's taken place. So thank you all. So we'll see you again soon on another webinar. Thank you, everybody.
Thank you.